Today we're going to discuss our design for the anterior cervical spinal disc replacement. I'm Eli Karen.
I'm Charles Hill.
I'm Nick Dalton.
So, 60% of the population over the age of 40 have experienced some kind of degenerative disc disease. This leads to over 187,000 anterior cervical spine procedures done every year in the United States. The gold standard for this procedure is anterior cervical disc fusion, or ACDF. This is a process of removing the damaged disc from the anterior cervical spine and replacing it with either a graft, a cage, or an implant, and then it is fused together by a steel plate to promote fusion and stability. However, this has some complications, such that 25% of the patients will need resurgery within 10 years due to either a deformation in the spinal segment or adjacent segmental disease. The alternative to this procedure is cervical total disc replacement, which is very similar to ACDF, except it replaces a damaged disc with a biocompatible material that is able to promote bone growth. It aims to maintain segmental motion and mitigate and reduce the risk of ASD. However, this has its own complications, such that the wear debris from the fretting corrosion can cause damage to surrounding tissue, and this eventually leads to dislodgement of the prosthesis or inflammation due to an immune response.
Our approach consists of 2 plates with 2 anchors in top and bottom, with 4 springs that are in the core integrated in each of the plates. And there's also a hydrogel that is comprised in the core that surrounds the springs. Now the plates and anchors are made of a magnesium alloy called AZ31 that is coated with calcium phosphate. Now this material will allow for a slow degradation to allow for bony ingrowth and replacement, as well as no cytotoxic effect and a close modulus to that of bone to allow for proper bone growth. Once this is replaced with bone, it will surround the springs which were integrated into the magnesium alloy. Currently, magnesium alloys are being worked on by the FDA to come up with standards to approve them for medical devices, and companies are already in the clinical trials to approve this. The springs are made out of nitinol that is porous with a diamond-like carbon coating. Now, the diamond-like carbon coating prevents the galvanic corrosion between the dissimilar metals, as well as it provides a super elastic properties that maintains the shape as well as the range of motion of the device, and also allows for good compression strength when it comes to a shock absorber needed for the type of device. Also, for surgical time is decreased because you can train it to be smaller, so when it's implanted, you cut down on steps and then heat treat it to allow it to slowly expand to the desired height.
In between the end plates, there's also a hydrogel, as Charles previously mentioned. This hydrogel is a double network hydrogel that allows for an increased modulus, both tensile and compressive. Here, the focus is going to be on the compressive modulus. It'll be able to support the 2 end plates and our prosthesis, functioning similarly to the center of a natural cervical disc. There's not been a lot of biodegradation studies conducted on this hydrogel, but minimal testing has shown that it does not degrade quickly and may be a viable portion within our prosthesis. So moving on to the benefits costs. So the benefits of our device, firstly, it will prevent the overloading and degeneration of adjacent intervertebral discs. Our novel design with the spring system will also allow for better transmission of axial loading that will occur in the spine. So this will help maintain normal range of motion along with preventing dislodging of the prosthesis and improving biocompatibility with our design. So this will eliminate the need for resurgery that is common within ACDF. Also, on average, CTDR is about 10% cheaper for the initial surgery and about 30% cheaper over a 4-year span.
And the cost associated with the design will come from the fact that it is a multi-component device as well as a Class 3 device, which will take extreme measures to get it passed into the market from FDA approval and multiple testing, as well as the alloys used in the device are highly specialized, and for instance, nitinol is 400% more expensive than steel.
So moving on to our competition, there are 3 current FDA approved devices on the market. First is the ProDisc C. Some issues with this prosthesis are there is dysphagia experienced by patients, which is issues swallowing or passing food through the esophagus, along with heterotopic ossification, which is bony ingrowth into soft tissues, also causing patient discomfort. Moving on, there's the Bryan disc replacement, which has issues causing wound hematoma as the operative procedure is very invasive, so this also causes patient discomfort. And lastly is the Prestige disc replacement, which experiences metal corrosion and fretting, creating cytotoxic ions within the patient. So if our device is not adopted as opposed to these three current on the market, there will be continued patient discomfort and need for post-operative surgeries.
We hope to appeal to surgeons that conduct spinal surgery on a regular basis so that they can help improve the future of spinal surgery and help benefit patients that receive the treatment.